Hello everyone. So let us start with a fresh topic, melanoma. Alright, so as you can see on the screen, this is a quite well differentiated melanoma. Yes, so first of all, I just want to put up a straight up question. Yes, so that is how would you describe it? Yes, that is the first thing, because as we go ahead in this discussion, the main thing about this topic is going to be how are we going to classify it. Okay, when we see a melanoma, what is the difference between just a normal regular mole and a melanoma? Alright, fine. So let us start our discussion. Yes, so the basic thing is that there are mutations which arise from the melanocyte. Okay, as also I'd like to get your attention to these three images, that they can be, the melanocyte can also be on the thumb region, that is beneath the nail, right? So it is, when we see this, so we don't really have this name ringing in our head that it could be a melanoma, but in this case it is. Yes, and as we go ahead, we will see the classification. Yes, and we will make a diagnosis that why we are calling it as a melanoma and not a regular mole. Alright, so let us see some predisposing factors. First of all, being the fair skin. This was the same as when we did the basal cell carcinoma and also the squamous cell carcinoma. Both of these findings had the predisposition was having a fairer skin. Yes, tanning beds and having a large quantity of nevi on the body. Yes, this definitely gets us to having a predisposition, because if there are a lot of nevi on the body, the main thing is that if there is some irregularities, we will not be able to pick that one out, right? Because there are a lot of them. So generally we think that okay, fine, it is okay, but a lot of nevi on the body gets having a predisposition, okay, of this. The next one is having the white skin, then someone who is on an immunosuppression therapy. Okay, could be somebody who accepted an organ, yes, somebody who was a recipient. Okay, and let us come to the most common presenting symptom of the melanocyte. This is if we have a new mole formation. Yes, so let me just write it down. If we have a development of new mole, or if there was change in color or size, yes, of the existing mole. Okay, so this becomes a very classical finding. Yes, in melanoma there is change in size, or if there was a little bit differentiation increase, yes, the increase in differentiation of the melanoma, we can tends us to get the diagnosis is more towards a melanoma. Alright, fine. So let us see to the more presenting symptoms. There we can have itching, bleeding or ulceration, which but these findings are very less. More or less we don't really have any pruritus on the melanoma, right? And let us come to this topic, is the star topic, yes, of the melanoma. So how would we diagnose? Yes, this is the classification, that is the ABCDE classification, is pretty standard, right? So A, let us write it down. A is for asymmetry, B is for border irregularity, C is for the color variation, D is for the diameter, and E is for the evolution of skin. Alright, so we have to remember this very clearly. The classification, it is a very must. Yes, okay, so A is for asymmetry, B is for the borders, C is for colors, D is diameter, E is evolution of the skin. Okay, So we have this done. Now what are we going to do is all the images that we saw, we will apply this and just try to see what conclusion we come up with. And meanwhile, I have one question here, that what is the most important factor when we see a melanoma? What is the most important factor? Alright, so this is a PYT, this is actually a PYQ, right? And it is one of the very star question. Okay, alright, so let us just go ahead and how about, let me just draw the margins of this lesions, right? So A is for asymmetry, right? Do you think this is a very symmetrical? Definitely not, right? Yes, this is not symmetrical. Yes, and the second point is B, A, B, C, D and E. Okay, A is for asymmetry, B we just checked out the borders, yes, and C for color. For color we can just try to zoom it in. We can see like there is very clear demarcation in this in the color we see, right? The way the skin is evolving, it is quite light and the central part is very dark. Yes, okay, and D is the diameter. Why we have to see the diameter is we have to check that if a patient comes to us and the patient says that, okay doctor, I was having this lesion, yes, so okay fine, you had this lesion, and we are able to see all these manifestations we can see clearly. But what questions we can ask is, what was the size of this lesion 2 months back? Yes, and the patient is going to go like, okay fine, no doctor, the size is same, I don't see. And probably we can ask for some photographs, yes, of the same lesion, right? We can ask for some photograph and we can just match it out if there are. And if there is size, if the diameter is increased, the diagnosis is going towards melanoma. Alright, and E is the evolution of the skin. We can see the way the skin is progressing outside. Okay, so that was all about the diagnosis part, right? Let's come back to the question I asked you guys sometime back, that what is the most important factor? Yes, so the answer is the depth of invasion. Depth of, definitely for that we have to know the depth, we have to take a biopsy, only then we can find it out, right? Okay, and let us come to the next topic, that is the physical examination, right? So it's pretty obvious, right? So the patient is going to come, we have some lesions, right? So what is the most important point here is that we have to examine the patient completely, right? So complete examination of the patient should be done, so entire body should be examined. Body should be alright, so especially we have to examine the foot, soles, fingernails, yes, the scalp area and the rectum, because if there are any findings in these locations, we should be able to properly get it, right? So okay, and fingernails are also important. We also saw an image related to this, right? Okay, so what is going to be the diagnosis, as we will have to do an excisional biopsy. Okay, gold standard is excisional biopsy has to be done. So by doing this, only then we can see the depth of the invasion. That is the most important factor, right, in all of the classification. Okay, all right. Imaging studies not really used, yes, only used when there is metastasis, yes, and complications, we can have some scarring, keloid formation can be there, and metastasis, yes. Keloid formation, this is a whole different topic, right? Keloid, this is a surgery topic, yes, and also overlaps with derma, yes, for sure. Yes, so what is the most important prognostic factor if we go for this is the tumor thickness and the presence of the ulcer. Tumor and presence of ulcer. Presence of ulcer. Okay, alright, so okay, fine. So presence of ulcer is going to be the prognostic factor. Yes, treatment, for sure we will have to excise it. Yes, we will have to have a very clear excision. Yes, and have negative marking. Negative marking means that we should have a clear border. There should be complete excision of the melanoma. Alright, and adjuvant medications are used. Adjuvant means the supporting medications are used when there are distant margins. Okay, and Mohs surgery is best for excision. Why? Because of cosmetic reasons. The same surgery name we did use in basal cell carcinoma, squamous cell carcinoma, right? Okay, and what are the predisposing factors in performing the Mohs surgery is the margin should be very clear, right? If there are clear margins, we can perform this surgery. Okay, alright, so this brings us to the end of this topic. Thank you so much for listening.